Good afternoon, everyone. Welcome to the Department of Internal Medicine Grand Rounds on this Good Friday, April 10th, 2020. It's my pleasure to have one of our own faculty present today. This is Mark Fendrick. I'm just going to give you a brief introduction. He has listed his slides already on the link that's already on the opening slide here. So Dr. Fendrick is a graduate from the University of Pennsylvania for his bachelor's and Harvard Medical School for his MD. He did his internship and residency through the Department of Internal Medicine at the University of Pennsylvania, and was a Robert Wood Johnson Clinical Foundation scholar program through the University of Pennsylvania as well. Mark is best known for his work in value-based insurance design. He is currently a professor in our Division of General Medicine, professor in the Department of Health Management and Policy in the School of Public Health, and he's currently the director of the Center for Value-Based Insurance Design through the School of Public Health. Mark has done a number of testimonies for the United States Senate, the United States House of Representatives, the State of Michigan Senate, and Armed Service Personnel Committee, and the U.S. House of Representatives. He's an elected member of the National Academy of Medicine, and he's won several awards, including the Healthcare Research Award from the National Institutes for Healthcare Management and Foundations. He has published over 270 papers, and he's been a consultant to a number of different organizations on value-based insurance design. So Dr. Fendrick is going to talk today on value-based insurance design, enhancing access and affordability to essential clinical services during this COVID-19 outbreak and beyond. So Dr. Fendrick, take it away.
John, thank you so much for inviting me, and thank all of you for taking time out of your busy schedules during this challenging time. I'm very excited to talk about our work, value-based insurance design. The department, my division, and the Institute of Healthcare Policy and Innovation have been extraordinarily helpful in our extending this work into the national healthcare transformation landscape. As John mentioned, I am a practicing general internist, and like many of you who are specialists, I pride myself in being a little bit wider and not as deep. In fact, I was introduced to the U.S. Congress as the shallowest person in American medicine, to which many of you who work in the field of genomics would find somewhat insulting, but I take that as a very positive kind of affirmation of my work over my 25 years here at Michigan, including work in just about every division in the department. I think I've co-authored a paper in people in just about every department in Michigan medicine, as well as work with several people across the campus. So it kind of abides by my broader as opposed to deeper type of approach. And as people are settling in, I wanted to show folks my probably shallowest of all the work I've done, which is this slide showing risk factors for falling asleep at lectures. And while this study was done a long time ago, long before virtual presentations, my research question for today is watching Grand Rounds virtually a risk factor for nodding off? And maybe when you fill out your evaluation, you could say whether you fell asleep during this hour or not. I know for sure that this person that many of us know, our previous chief resident, Kevin Platt, is probably sleeping already with his wonderful new son. So here we go. I think what's most important for me, having the honor to give Grand Rounds, is to not forget what we've been going through. And I want to send my thanks out to John and everyone in the department and everyone in Michigan Medicine, and actually everyone across the globe who are doing so many selfless tasks and wonderful things to successfully defeat this pandemic. And here's a picture from the parade of first responders this week that kind of brought to bear the amazing efforts that's going on. So for those of you who are looking at this virtually who did not have the time to spend this afternoon while you were fighting the epidemic front line, my thoughts and appreciation go out to you. So it's a very interesting time, and many of us are thinking about what is healthcare going to be like in the what I call the new normal post-COVID. And whether it be before COVID or after COVID, I'd like to remind most of you are clinicians that while many of us are so unbelievably excited about what we could do to treat individuals and populations regarding reducing morbidity and mortality. When you walk out of the hallowed halls of Ann Arbor or other institutions where you might be, the main focus of healthcare reform, I believe it was before COVID and certainly after COVID, is how to cut healthcare spending. What's important for us in the clinical arena is that almost all the things that we beg our patients to do are underutilized. This goes for preventive care that we often do in primary care. This even goes further to the most subspecialty care, where we know many of our patients are unable to get the care that we know that will improve their quality and length of life. As sitting in an academic center as great as University of Michigan, it's really interesting for me to be unbelievably excited about what's coming down the pike. But what's really concerning at the same time is our ability to deliver the amazing innovations that we've come up with has actually lagged behind the ability for great science and implementation to move forward. Such so when I speak to people outside of our hallowed halls and ivory towers, I call what we can do Star Wars science. And in the 27 years I've been practicing internal medicine, it's just remarkable, just in that period of time, how much better the science and the evidence has become for us to improve quality of length of life. The problem in that many of us who do health services work see is that although we can do certain things, we often are unable to get our patients to find the infrastructure to allow the processes to deliver the care that we know they will make them better, whether it be on an individual or population basis. Thus, I call this Flintstones delivery. Now, some of the residents and medical students may not know who Fred Flintstone is. Dr. Carruthers can certainly tell you about Fred and Barney and understand that many of us find it very frustrating that we see the opportunities to improve the health of individual patients, but there are often barriers in place that do not allow us to actually do our craft at the highest level possible. So the charge here, of course, is moving from the Stone Age of Fred Flintstone to the space age of Luke Skywalker. And we have been talking at the VBIT Center now for 15 years, how we could hopefully change the healthcare transformation and cost discussion from how much we spend on healthcare, which is their focus, to how well we spend our trillions of dollars on healthcare. So the good news is that almost everyone agrees that $3.7 trillion is enough. It's just we spend it on the wrong services and in the wrong places. And while people deliberate on the future of healthcare in terms of how we providers are paid, I think it's really important and underestimated the role of our patients. These provider-facing initiatives, how we pay people, should also be balanced and aligned what I would call a patient-facing approach. And what's very interesting that for the 20 years I've been looking at patient-centered strategies, consumer cost sharing, meaning how much patients have to pay to see their doctor or fill their prescription, has been the prominent patient-facing strategy. The problem is consumer cost sharing has been implemented in what we call a blunt instrument, in that patients pay more out of pocket for all care, regardless of clinical value. In other words, they pay a lot for the things we beg them to do. They also pay a lot for the things that will not make them healthier, the ultimate definition of a blunt instrument. So when Mike Chernow, who was with us at Michigan for many years now at Harvard Medical School, and I started looking at out-of-pocket costs, or what some people call skin in the game, we used to look at co-payments, a direct cost that you had to pay to fill your prescription or get a diagnostic test. But what we've really been focusing on in the past few years is health plan deductibles. These are the part of health plans that it's a set amount that you have to pay before your insurance kicks in. Now, I've heard that 50% of millennials don't know what a deductible is. All 4 of my kids have crashed at least one of my cars, so they certainly know what a deductible is. So we have to transfer the information in other types of insurance to health insurance for us to get a handle on the fact that having insurance doesn't mean you have coverage. Thus, that hashtag insured but not covered or underinsurance has been an important area of interest for the VBIT Center. And as you can see here, that deductibles have risen remarkably quickly over the past decade. And the average deductible, these are people with employer-sponsored health insurance, have to pay over $1,000 out of pocket before their insurance kicks in. The average for families is between high $2,000s and $4,000, with some families paying up to $10,000 before their insurance actually starts paying for the care received. So this is probably my most important message to all of you as you engage in, say, the upcoming election or the policy discussion about healthcare transformation. Americans do not care about healthcare costs. They care about what it costs them. Well, Dr. Carruthers and the leadership team of the Department of Michigan Medicine should care about overall healthcare costs. Why healthcare costs has become not the number one health policy issue, but the number one public policy issue in the United States is what our patients are paying to see us in the clinic, and more commonly, what they're paying to fill their prescriptions at the pharmacy. People are not worried about the cost of insulin to an employer or the federal government. They are worried about what they have to pay at the pharmacy to get the drugs they need. And that has been an intense focus of our work, trying to convince policymakers, while the price of a cardiac catheterization or the price of an ICU stay is important, what really matters to the typical voter or consumer is what they have to pay out of pocket. So my inspiration, as you see here all along in looking at a research agenda to examine the impact of consumer cost sharing, my now 86-year-old mother, as of last week, said to me 20 years ago, "I can't believe you had to spend $1 million in grant funding to show that if you make people pay more for something, they will buy less of it," right? So imagine an easier academic agenda than doing a study of the impact of making people pay more to see the doctor. They go less. Making people pay more to fill their prescriptions. They fill less. Making people pay more to get their preventive services. They do them less. So like all of you, my mother was right. And there is now a very robust body of evidence showing that this idea of skin in the game or making people pay more for high value services, they buy less of it. They do buy less of low value services, but unfortunately Americans have not been able to discriminate with their own money to buy more of the good stuff and less of the bad stuff. And with these blunt instruments, it's basically been buy less of everything. So you can imagine when I told my mother that we had to get another grant to show that increasing consumer cost sharing impacts poor people and people with chronic diseases more than rich people. But again, as part of this Homer Simpson-esque research agenda, we needed to do really strong empirical work to show that this idea of shifting costs to patients in a blunt way worsens disparities and particularly adversely affects health for those who are socioeconomically challenged and those with multiple chronic conditions. So skin in the game, not working in terms of discriminating between high and low value services and making disparities worse. So here comes COVID. And I'll tell you that my view in the Wayne Gretzky view of the world, I am not focusing on COVID-19 like so many of my colleagues who are on the front line. I've been asked by many constituents to think about what will life be in healthcare post-COVID. And my strong view is a second healthcare pandemic will follow COVID-19, and we need to plan accordingly. And while it impacts the people who have been afflicted with coronavirus, it's very important to know that there are many people with multiple chronic conditions who are not seeing us in our offices, not that getting their recommended labs and follow-up tests, and not even presenting to the emergency rooms. We're seeing drop-offs in MIs and urosepsis and strokes and broken bones. And there are lots of reasons why we are not seeing that volume of patients, but we do know already in the relatively early stages of the pandemic from an economic standpoint that nearly 3 in 4 Americans have already had their income hit. I told you that before COVID that there was amazingly common problems of people not being able to afford the care they need. So as this amazing research comes out in real time, 68% of people report that out-of-pocket costs would be very or somewhat important in their decision to get care even if they had coronavirus symptoms. And this analysis from the Commonwealth Fund and others tells us that if a patient with insurance were hospitalized, they would be responsible for $1,000 at least for a hospitalization. This is with commercial insurance on the left of the right slide. This is with traditional Medicare or Medicare Advantage. People would be on the hook for $1,000. Why is this important? Why was this so important even before COVID? Is that 40% of Americans do not have $400 for an expected expense. So if the typical deductible for the American with insurance is $1,000, and 40% of Americans do not have $400 in the bank, you can imagine that there is a rub here. Thus, that I am working very hard with several colleagues here in Michigan and across the country to make the point that Americans cannot afford a COVID-19 deductible. This second wave that I'm talking about is going to hit all of Americans, most notably those who are socioeconomically challenged and those with chronic diseases. The projections already that premiums are going to go up, that cost sharing is going to go up, and then the recession, which now we have tens of millions of people unemployed, are going to increase uninsurance rates and test Medicaid. We're so lucky here in Michigan in my division at IHBI to have national leaders who have already been able to carefully and rigorously look at the impact of uninsurance, Medicaid expansion, and underinsurance. And this will only make them busier. And I'm afraid that unless we put certain policies in place now, the concerns that we have of underuse of effective care and the worsening of healthcare disparities that we're already seeing in the COVID hospitalization and deaths will extend further into the conditions that we were taking care of before this pandemic hit us. So what's a potential solution? And going back now, sadly or happily, 20 years ago or more to the last century, Dr. Chernow and I came up with an idea that instead of having these blunt approaches, a deductible that you have to pay for the highest value service or the lowest value service, that we instead come up with the design of a smarter cost-sharing approach that is clinically driven, that would make it easier for our patients to do the services we beg them to do, and would discourage them to do the things that are not making them any easier. Here is a picture of Kang's Korean restaurant, which is one of the many restaurants that was providing free meals to healthcare providers during the pandemic. It was in the late 1990s, I sat with Mike Chernow over a bibimbap, and we talked about an idea that would redesign insurance around one simple but elusive goal: make the good stuff more accessible than the bad stuff. We were fortunate last December to have a national podcast called Trade-Offs kind of make fun of us as we've been on this journey. I recommend for those of you who are taking walks or need some solace to get away from COVID to follow this link and listen to how Dan Gorenstein of the Trade-Offs podcast has kind of told our story about how we got from a bibimbap to some very important national policy implications, which I'll talk about in a bit. So what is VBID? I think it's something that my mom could have come up with, all of you could have come up with if I explained to you the problems of the current benefit design system, which currently sets consumer cost sharing on the price of a service. How instead would it be better for patients if we set consumer cost sharing on the clinical benefit? That means little or no out-of-pocket costs for the high-value care and higher cost sharing for the low-value care. And we were lucky enough to talk to largely private employers in the early 2000s, and we convinced them that it would be a good idea, since they had greater control over their benefit design, to make things like diabetes therapy and antihypertension and antidepressants less expensive, regardless of the class of the formulary, than drugs to treat toenail fungus and male pattern baldness. And we started with a small incremental effect, thus so that folks in the U.S. Capitol Hill often call me the tortoise in the healthcare reform rate. We are incrementalists. We understand we're not going to turn the system upside down, but it's been very exciting for us as we move forward to tell people there's more than enough money in the system and we should spend more on the good stuff and less of the bad stuff, that both Republicans and Democrats, through the heat of the anti-ACA or Obamacare discussion, tend to say that's probably a good idea. And you see from this slide, we stopped adding organizations a long time ago. But organizations that tend not to get along very much, like the U.S. Chamber of Commerce and the country's largest union, agree with value-based insurance design. People who make drugs and people who buy drugs tend not to get along very well, but they support value-based insurance design. And while there are much more important and sophisticated and impactful ideas for the past 15 years or so, value-based insurance design has largely stood and persisted because it's rare, bipartisan, and broad multi-stakeholder support, which I'll talk to you about in a second. So many of you, so we have basic sciences, we have translational scientists, we have health services researchers, but it's pretty rare that until IHPI and John Ayanian's fantastic leadership, that faculty members, particularly in the Department of Internal Medicine, would take the step out of academia and move forward into the public policy space. I've told many of my colleagues and collaborators that I published and I still perished in the fact that people liked the idea of value-based insurance design. We had really good research backing up the idea of value-based insurance design, but it really was going nowhere if people were going to measure our success regarding PubMed citations. So I decided to take a bold move, guided by the School of Public Health's head of government relations, to bring the VBID idea to the US Capitol in the mid-2000s. You need to understand that many of you have advanced degrees and public policy experience. I was guided by our friend on the right side of this slide, the gentleman from Schoolhouse Rock. Before my first set of meetings in 2006 on the Hill, I was literally singing, "I'm just a bill, I'm only a bill," because that's all I knew about how you can bring an idea into the public policy realm. Well, thanks to the help of so many people, and Jen Martin in particular, we had the great opportunity to participate in one of the transformational healthcare reform movements of US history, which is the Patient Protection Affordable Care Act, also known as Obamacare. And as some of you on this webinar might be pro-Obamacare or anti-Obamacare, and I've traveled to 49 states talking about value-based insurance design, I do not ask you to support all 900 pages of this very impressive law. All I ask you to do is to support one half of one page that we helped write, which is the VBID portion of the ACA, which probably all of you clinicians know about, but did not know perhaps that it has roots here at the University of Michigan. This enormously popular section, supported by both Republicans and Democrats, is the section that mandates that health plans cover with $0 cost sharing now over 100 preventive services as determined by an A or B rating of the U.S. Preventive Services Task Force, immunizations recommended by the ACAP of the CDC, and certain family, women's health, and child services recommended by HRSA. My guess is all of you, almost all of your parents, and almost everyone you know have received expanded coverage of preventive services under this tiny part of the ACA, which was preserved in all but one of the 40-plus repeal and replace actions, because who's not for pre-hypertension, obesity, and smoking cessation counseling? Who is not for low-cost CDC recommendation vaccines? It's really been an interesting ride for us trying to get people to understand that if it wasn't for our initial efforts 2 years before the ACA educating Republican and Democratic staff on the blunt instruments of cost sharing, that maybe this important and impactful section of the Affordable Care Act may not have occurred. This is a gift that keeps on giving. And I added this new slide for a clinical audience just to remind you, in the past year, these 7 services have been designated an A or B rating by the U.S. Preventive Services Task Force, meaning that in 2021, these services must be in patients in non-grandfathered health plans, which is about 90% of covered Americans pre-Medicare, can get these services at no cost to them. This includes pre-exposure prophylaxis for HIV, which now only 10% of indicated patients get it, and most of them don't get it because they can't afford it. This includes breast cancer preventive medication for women at increased risk. This includes the very recent expansion of hepatitis C screening from the baby boomers to now all adults between age 18 and 79. Real implications not only for general medicine and primary care, but for all of the specialists that see the patients down the road from these preventive care services and early diagnostics and counseling. So we had this big success in commercial health plans. What I felt all along in our initial impressions in bringing VBID to the national public policy space is that the population that would benefit most from lower cost sharing for selected high value services would be the Medicare population. But as you all know, if you take care of Medicare patients, 98% of the spend in these elderly and disabled individuals in the United States is on chronic disease care, which was explicitly not included in the primary preventive definition of Section 2713 of the ACA. So coming off the high of the ACA inclusion of VBID, our team decided to try to include VBID elements into the Medicare program because we felt the benefits would be enormous. It's important to understand that while there's a lot of talk and rhetoric about Medicare for all and certain policies in the media that Medicare means no premiums and no out-of-pocket costs, you see from this slide that the average Medicare beneficiary out-of-pocket spending exceeds $5,000. So the same thing holds true as we were talking about in commercial, that a lot of these people on fixed incomes don't have the money to overcome their deductibles. And to show this, Dan Klein and I, the Patient Assistance Network, published an op-ed just last month showing that people who apply for grants to afford their high-cost, high-value medications triple in January as opposed to other months. This is not because healthcare costs are seasonal in the Medicare population. This is because when the year turns over, your deductible hits in again, and a lot of people don't have the money to stay on their medications for their autoimmune disorders, for their cancers, for their cardiovascular disease. And we have to figure out a way to somehow reduce this January effect for Medicare Part D beneficiaries to allow them to get the care they need throughout the entire year. So going back to our friend from Schoolhouse Rock, why would it be so hard to put VBID in Medicare? It's got bipartisan support, it's got a good idea. And lo and behold, when people who knew a little bit about legislative and regulatory information said, one of the most important aspects of the Medicare bill when passed in 1965 was something called the Anti-Discrimination Clause. And the Anti-Discrimination Clause made it very, very, very clear that every Medicare beneficiary, no matter what your age, no matter what your gender, no matter what your color, everyone had to have the same benefit design. And for those of you who work in genomics and precision medicine, you know now that benefit design and delivery of medical care should be down to the patient level, let alone the gene level. So there is a direct battle between the non-discrimination clause and what we want to do in precision medicine and precision benefit design, another name for value-based insurance design. So at the time, our constituent congressman, all of us in Ann Arbor, was John Dingell. You see on the right of the slide, one of my heroes. And John Dingell, as many of us in the policy space know, was integral in the passage of Medicare in 1965 and made it very clear to me that the non-discrimination clause was never waived and unlikely to be waived, and told me in this quote on this slide, implementing VBID in Medicare will take an act of Congress. For those of you who know the chairman, Mr. Dingell, what that really means is get your ass back on the plane to Ann Arbor and keep doing research, let the policy making up to me. But it turns out, for those of you who know me or could see me, my forehead is rather flat. Because I thought the idea of VBID was such a good idea, I just banged my forehead against the wall over and over and over. And with the thanks of Jen Martin and the government relations people, we were able to convince our friends in Congress to introduce a bill, our friend on the right, that required the utilization of value-based insurance design in the Medicare program. As you see in 2015, this was at the height of the anti-Obamacare. Nothing was getting done on health care. This bill passed the House unanimously, was on its way to the Senate when the Obama administration said, if this is an idea that has bipartisan support, we will put in place the Medicare Advantage value-based insurance design model. This was in 2016. This was in 7 states and 7 conditions, and we were very concerned with the turnover from the Obama administration, who supported this a great deal, that when the Trump administration came into power, that the VBID model test would be at risk. We couldn't be more surprised that early on in the Trump administration, they took the VBID model and expanded it to what Secretary Azar and Administrator Verma call VBID 2.0. Not only did they expand the model test from 7 states to all 50 now, and many people say this is the only CMMI model that has been started under the Obama administration and expanded under the Trump administration. But very recently, CMMI has announced some really exciting expanded opportunities for the MA VBID model test, which you can see on the VBID website. But in addition to the reduced cost sharing for specific services, like an eye exam just for a diabetic, high value providers, a provider or group that does better in terms of quality and cost in managing a particular disease, or if you could get your cost sharing lowered for your diabetes medications if you participated in a disease management program. But even more exciting to me, which has been on our radar for a long time, are some of these items that you can see on the right. I don't have time to go into them in great detail, but I will tell you that in the late 1990s, I went to a health plan in Detroit to convince them to cover an air conditioner for a patient who was admitted 3 times every summer for obstructive lung disease and asthma because the trigger was heat. And I was literally laughed out of the room in suggesting that a health insurer should cover an air conditioner to take care of someone's medical problems. Here we are in 2020, and Medicare Advantage will allow coverage of things like air conditioners for people with asthma, pest control, and importantly in the top right, transportation and nutrition support. These socioeconomic determinants that are traditionally been outside the medical insurance system are now being brought in as many of us think about a broader population health approach. And which may have been somewhat prescient, we had argued for years to expand telehealth in the Medicare program, understanding that sometimes patients were not able to see a provider, or in other situations that we're learning very quickly now, as many of us are doing telehealth visits, there are some visits that can be adequately maintained by just having a virtual visit as opposed to a face-to-face one. To show that the Trump administration continues to look at lowering out-of-pocket costs for high-value services in the VBID principled approach, just before we started really concentrating on COVID, which many of you may not have heard of, CMS has launched for the first time a new insurance model that will lower out-of-pocket expenses for insulin for Medicare beneficiaries. Again, a small start, a single medication, but showing that you can convince policymakers that a good idea can actually move forward and be implemented to at-risk individuals. So I wish I had more time to talk about how VBID spread across this magnificent building you see in front of you, the U.S. Capitol. But as Dr. Carruthers mentioned, I had the honor to testify in front of the Senate around the role of VBID in Medicare. And I was very fortunate to have in the audience with me another one of my heroes, Senator John McCain, who happened to be the chair of the Senate Armed Services Committee. And he came up to me and said, "This idea sounds good for Medicare. I think it's really good idea for those in the armed services and the retirees as represented in the TRICARE insurance program." And in 2017, President Obama signed a law that reduced or eliminated cost sharing for high value services and providers, kind of VBID classic. And then in 2018, President Trump signed further implementation of VBID principles into the TRICARE program. And these conversations and improvements go on today. So you can imagine what a great honor it is for me to not only talk about privately insured in the Medicare program, to actually make a difference in the health insurance products that are delivered for those people who are serving our country and keeping our country safe. I just want to talk a little bit about the dreaded deductibles and our work in health saving account qualified high deductible health plans, or HSA HDHPs. Very briefly, I'll just tell you that under the Bush administration, when health saving account high deductible health plans were created, a single sentence was put in the IRS code regulating these plans that said very explicitly that high deductible health plans could not cover clinical services used to treat, I quote, existing illness, injury, or conditions until the plan deductible was met. Now, you see from this slide that Section 2713 of the ACA mandates that these high deductible health plans have to cover the 100 or so services that are designated by Section 2713. So you could get a free mammogram, but not get coverage for the care until your deductible is met. You could get screened for diabetes, but you cannot get coverage until your deductible is met for your insulin, your hyperlipidemia meds, and your antihypertensions. So the follow-on care that comes from preventive care would put patients in a really difficult situation, such that I would rather not know a patient has a disease if they know they can't treat it. And we've heard very recently from patients in Taubman Clinic that some of them will not undergo, say, something like a non-invasive colorectal cancer screening test, understanding that if it's positive, they don't have the money to pay for their very high value and potentially life-saving colonoscopy. So right from the immediate time where this code came out, those of us who really cared about moving VBIT forward decided to try to change this one sentence in the Department of Treasury code. We started writing peer-reviewed papers on the problem of consumer-directed or high deductible health plans. You see this is from 2007. And for 14 years, myself and colleagues and our very close friends at the Smarter Healthcare Coalition worked tirelessly in Congress, in patient advocates, key constituents, and most importantly to the Trump administration to convince them that allowing plans to cover high-value services on a pre-deductible basis would be a good idea and might actually save the government some money. And while most of us weren't paying attention to healthcare transformation, in the middle of the summer, the IRS released Notice 2019-45, which said for the first time ever that specific services and drugs used to treat chronic conditions can be covered before the plan deductible was met. So our little group at the VBIT Center and a lot of folks who fought for this for over a decade in Washington were having a mini celebration. But it's very important to understand that this notice is completely voluntary. And we've been trying to follow regarding what health plans are doing. And all I can tell you is that because it's voluntary and there's a lot going on as not happened, which is why we continued very hard to push our message that at least for these 14 services, many of which you would know as no-brainers, some of which our patients have trouble affording, can now be covered on a pre-deductible basis. And very importantly, that people don't have to pay full price for them when January comes around and the deductible kicks in. Thus, we have been arguing everywhere we can that if you have insurance, you shouldn't have to pay full price for insulin or statins or antidepressants or other types of things. But because insulin tends to be kind of the flag-bearing service in Washington around the service that should not have a cost share, we've been pushing insulin in particular. And as I mentioned earlier, the Trump administration has answered that plea by creating a new type of health plan that markedly lowers out-of-pocket costs for Medicare beneficiaries requiring insulin. So for those of you who looked at that list of 14 and said, that doesn't touch on any of my high-value services in rheumatology or orthopedics or emergency room medicine or other types of things, you need to understand that this success with the IRS notice is just an intermediate part of our journey to hopefully allow all plans the opportunity and flexibility to cover whatever they want on a pre-deductible basis. And again, thanks to our friends at the Smarter Healthcare Coalition, in this Congress, I think is the fourth introduction of the Chronic Disease Management Act, Senate Bill 3200, which markedly expands the list of services that could be covered in these high deductible health plans on a pre-deductible basis. So while most researchers have been going inside for the COVID time, those of us in the VBID world have been busier than ever understanding that there are real concerns, as I mentioned earlier, about patients not being able to pay the price for their COVID care. So we immediately went to work, and on March 11th, and this is even really before people started paying attention to the pandemic here in the US, we were able to get an add-on to our IRS notice from last year to extend pre-deductible coverage from medical services to test and treat for the coronavirus. So it took us 14 years to get 14 services and 3 weeks to get COVID care, suggesting it's worthwhile to get these small breakthroughs to see things move forward. Just a week later, the Families First Coronavirus Response Act, the second of the 3 current coronavirus relief packages, again, explicitly included in that very large and very impressive law, was a section that eliminated cost sharing for COVID testing. So this is not pre-deductible coverage. This is you get your testing and your visit test for free. Now, unfortunately, if your test is negative, there's some issues as we're learning now that, again, the implementation of this is not pure regarding the spirit of this act. There are actually some ongoing work that we'll see in a week to show that there are still some patients who thought they were going in for a free COVID test who ended up paying. That is not different from patients who went in what they thought for a free colonoscopy who ended up paying. So the implementation has not been perfect. But this second bill also limited cost sharing for any in-person or telehealth visit that results in a COVID test. And this was the breakthrough we felt to get attention paid to payment for and reduced cost sharing of telemedicine, which is, in my experience just this morning, is 100% of the care that we do. So on March 27th, a week after that, came the $2.2 trillion Coronavirus Aid, Relief, and Economic Security Act, or the CARES Act. There was no rest from our friends in Washington on the accomplishments built on the Families First Act. They went further and allowed high deductible health plans to cover telehealth on a pre-deductible basis. So we added not just COVID-related telehealth, but all telehealth on a pre-deductible basis. It mandates coverage of COVID testing without cost sharing by all plans. So whatever concerns we had about implementation were clarified. And I think what's really exciting and forward-thinking that amends the VBID section of the ACA, Section 2713, requiring plans to cover a coronavirus vaccine without consumer cost sharing. The current Section 2713 says you have a year to reduce consumer cost sharing. So we're waiting for that, for instance, for PrEP for HIV. This amendment to Section 2713 says plans have 15 days to make the coronavirus vaccine no cost. And hopefully that will remove any concerns that eligible and indicated patients will get this vaccine when it becomes available. So unlike usually we're making laws after we need them, very excited to see that for the coronavirus vaccine, VBID principles are already in place, etched in stone, passed bipartisan, and signed by the president. So almost all of you, particularly those of you who my hat is tipped for taking care of COVID patients, either at West Ann Arbor or in the hospital, the progress we were making on the policy side was for testing. What about those $1,000 cost shares for hospitalizations? And because that was not included in the bills, although the fourth bill is considering it now, a lot of pressure has been put on major insurers to waive cost sharing for COVID treatment and hospitalizations. While this is not everybody and when it's optional, I'm just really pleased to see the way the national insurers like Aetna and Cigna and Humana and the Blues have stepped up to remove cost sharing. States where the governors have led so impressively in the response to COVID, New Mexico and Minnesota just said, you cannot charge patients out of pocket for COVID treatment and hospitalizations. And in a big surprise to many of us following the national policy trend, President Trump mentioned last week that actually the federal government will pay hospitals to treat the uninsured. at Medicare rates. So while not perfect, we're making headway implementing Viva principles in the COVID response. So there's probably someone on the phone saying, there goes Mark Fendrick again, saying we should cover all these things very generously. Who is going to pay for it? And I'm going to touch very briefly on what we were doing beforehand and what we're doing afterwards, feeling very strongly about how we pay for lower cost sharing on high value care. That's the clinical community has to come together and stop doing the things and making our patients pay out of pocket for the services that don't make them any healthier. Because the alternatives to low value care are increasing premiums on everybody, which you don't like that. We could raise deductibles and copayments even further, which is the whole driver for VBID. Mike Chernow and I call that a tax on the sick. So we've decided 5 years ago to focus on the sadly $800 billion or so dollars that are spent in the U.S. Inefficiently, of which 345 Will Schrank at Humana has shown is on low value care. And we have been working with purchasers, public and private, patient advocates, the federal government, to draw a focus on services that are ubiquitously used in the U.S. healthcare arena that do not make Americans healthier in a majority of circumstances. We brought together these purchasers in an organization called the Low Value Care Task Force. We wanted to call it the Waste Task Force, but WTF was already taken. So the Low Value Task Force came together and came up with these 5 actionable low value services that we believe, again, can start a process to get providers and patients to understand that there are services that are done very, very frequently in the United States to the tune of billions of dollars, that we could take that money from their reduced use and create headroom to allow us to pay for these VBID interventions that lower cost sharing and enhance access to the services that we beg our patients to do. So how do we put this all together in the last few minutes? So Mike Chernow, I've mentioned a few times, has begged me for 20 years to not just talk about high value services and low value services and not just list them, but actually create a health plan. Create a health plan with a group of folks called actuaries, which are the smartest people in the room who determine that when you cover certain things at a certain level, how much the premiums, the co-payments, and the deductibles will be. And what we set out to do was to find high value services and cover them pre-deductible and generously, and pay for them dollar for dollar with higher cost sharing or non-coverage on the services that we should not be provided unless in a prior authorization or very rare clinical scenario. And we call this VBID X because the Trump administration called on Mike Chernow and I to create a template of a benefit design for the state exchanges, thus X. And what we were charged to do was to expand coverage of high value care and use of high value care shown in the aqua on this slide, and pay for it entirely with reduced spending on low value care. So we're shifting from more low and less high to less low and more high. So more of the good stuff and less of the bad stuff. And we were hopeful that we could find this money without having to raise premiums or deductibles, which are a political non-starter. So we created this template by bringing together, again, 15 or 20 key constituents, the federal exchange people, the California exchange, the Massachusetts exchange, the folks from Blue Cross Blue Shield Association, America's health insurance plans. We had a bunch of experts in the room. You can imagine how hard it was. We came up with a number of services, not very different from those in IRS Notice 2019-45. These were the services and drugs that we determined in the template that would be made pre-deductible and free or nearly free in almost every situation. And you'll notice that there's a lot of drugs and some DME. We also included branded drugs that for which there were not generic equivalents like anti-TNFs and hepatitis C drugs. And to pay for them, we made as a group a very bold decision to not cover these 4 services and cover less generously a bunch of other services that were not as specific. And what the actuaries came up with was a situation of full coverage for the high value service, less generous coverage for the low value services, and premiums and deductibles stay the same. We published this. You could find this under VBIDX on the VBID Center website, lots of details. And we published a blog, and like most things VBID, we thought we would publish, and we still perish. Lo and behold, a month and a half ago, the Trump administration, as every administration puts out every year, something called the proposed payment rule for federally qualified plans. In this 265-page document, there was the strongest endorsement you could ever imagine for VBIDX. There was explicit note of the University of Michigan Center for Value-Based Insurance Design, and they printed our template services high and low value verbatim. So some people are calling this the second coming of VBID. Some people are calling it the third coming of VBID. Most of you are saying this is the first coming of VBID, never heard it before. But it's so kind of validating in the really turbulent public policy times that we're in, particularly around healthcare, that a simple idea of covering services that we need our patients to take more generously and paying for them with services that we shouldn't be buying is actually making some headway. So as I wrap up here and think about where we're all sitting, at least those listening today live during the COVID epidemic, where will VBID sit in the new normal of healthcare delivery? And one of my research associates, Beth Shrosby, and I wrote an editorial that was published this Monday that basically states that the COVID pandemic had uncovered a flaw that many of us have known about in current benefit designs, showing that even if you have insurance, you don't have coverage for the care you need, whether it be for COVID care or not. And we feel strongly that now COVID has really exposed the underinsurance problems. The time has come for payers, public and private alike, to revisit benefit designs and allow better access to the care that we clinicians determine to be the highest value, and that deter the use of the services that we clinicians, such as those designated by the Choosing Wisely program, which has been so influential to our work in low value care, to allow us to pay in terms of headroom for this high value care. So here is where we think VBID is in the new normal. First is we continue to fight hard to expand pre-deductible coverage and reduce cost sharing on high value services. That has been what I've been dedicated to for now a quarter of a century. That is the core of our VBID work. We understand that to pay for Star Wars science, we also have to get serious about the identification, measurement, and removal of low and no value care to allow us to pay for more of these high value services. And now that we have templates like VBIDX, we could turn to the Department of Defense, we could turn to state exchanges, we could turn to Medicaid programs and the Medicare program and commercial insurers and tell them that they could put these programs in place and not have to worry about higher premiums or deductibles. So I like to close every one of my presentations with my favorite political quote of all time. I show this particularly for Marcus Geer and his beautiful new son because, you know, Buckeyes out there tend to rankle when they see the big house. But my view about moving forward the VBID idea with the support of my division chief, Larry McMahon, and the hundreds of colleagues here at U of M and across the country is really capsulized nicely in this quote from Dan Quayle, who said, "If we don't succeed, then we will fail." And with that, I want to close and show you a picture that our chairman, John Carruthers, shared with all of us in the department a few days ago. And that as we think about these dark times of COVID-19, we have to remember that the greater the storm, the brighter the rainbow. And to all of you, my colleagues on the front line, thank you very much. And with that, John, I'll turn it back to you.
Thank you, Mark. I'm going to go ahead and read some questions. I think that your talk was very eye-opening, and I'm glad that you've worked on this for many years and starting to make headway with our legal system throughout the state and throughout the country. So a question comes from Barb Soyster. She mentions that generic insulin in vials of $25 for 1,000 units, generic insulin in, but the Lantus is $200 for 1,000 units, so many times more. Are you proposing the same or different co-pays, the amount the patient pays for these two different types of insulin, or would you propose different cost sharing? And would that involve the glucose monitoring, if not the insulin, as an example?
So, no, these are all great examples, and I'm hopeful that we could get more general things. But in our work, particularly in the post pre-deductible discussion, several plans that I'm working with are willing to put one insulin on the 5 or 6, depending on various clinicians and pharmacists, 5 or 6 classes on a pre-deductible basis. So what I need to tell Barbara and others is my fight is that patients don't pay full price, let alone a copay or cost share. There are several of the organizations that I'm working with that will put one insulin of 6 classes of insulin on a first tier of a formulary. And in some instances, I've convinced them to make all 6, one of each of the classes, free. So I hope to find one day an organization that's willing to put all insulins and give complete discretion to clinicians to prescribe whatever they want. But given that we know in every January there are thousands of American diabetics who cannot get any insulin at all because of the deductible problem, that's the battle we've been fighting, understanding that clinicians could fight even further to make the changes more granular.
Okay, thank you. Raj Saran writes, what are your views on universal health care coverage for the U.S.? Some of the VBID principles apply there. Outcomes could be better in countries when there's a universal health coverage at lower cost. Have you been practicing VBID without calling it just that?
So, John, you should do a better job of screening the political questions out. What I'll tell you is, regardless of whether it's Medicare for all or universal health care or a very, very skinny high deductible health plan, we clinicians have to be very actively involved in the benefit design that's created. So there are many situations in other countries that I've studied well that do not provide access at reasonable levels of granularity to services that our subspecialists would recommend. So what we've been doing for 20 years is to convince payers that all services are not equal. All visits are not equal, our diagnostic tests are not equal, all drugs are not equal in a tier of a formulary. And we've had significant success making high-value visits less expensive and high-value diagnostics and drugs less expensive. It has been an extraordinarily tough battle. I think you know me personally, John. I am a singles hitter, not a home run hitter. And if at best I'm an infield singles hitter in terms of taking these small victories. So decisions about how the overall healthcare system should be designed and paid for is above my pay grade. But I do, regardless of how it's set up and regardless of what the benefit design is, the services that all of us clinicians deem to be highest value and potentially life-saving, my patient should not have to have a bake sale to afford her insulin. And our patient should not have to have a Kickstarter campaign to get a cancer drug that was designed to treat her tumor. And, the battles I've been fighting are more granular than the macro changes that are suggested by that question.
Okay, thank you, Mark. Another question mentions that these cost savings are great. I don't think anyone would disagree with increasing coverage for high-value care. But they suggest that the costs associated with low-value care are only a minor fraction of the cost of the U.S. healthcare system. What about the uninsured, administrative overhead, for-profit insurance, those types of things?
Right. So that's the point. So I don't know who that patient's reading and saying low-value care is a small proportion of our healthcare spend. I don't want to turn to cardiologists, gastroenterologists, radiologists, orthopedic surgeons, and all the other organizations that have taken choosing wisely seriously. But we know it's hundreds of billions of dollars, and you could cover a lot of high-value services in the Medicare program if we just got rid of, say, pre-op testing before cataract surgery and prostate-specific antigen testing for men over 70. So I'm completely agreeing that if you read Don Berwick's work and Will Schrank's work on the potentially near $1 trillion waste, which is site of care, inefficiency, and other types of things, we tend to focus on specific services. And I think it's harder than people think, because it's difficult to get a man to understand something if his salary depends on him not understanding it. And as long as people get paid for doing colonoscopies on 88-year-olds and putting stents in people with stable angina and doing knee arthroscopies and my favorite, vitamin D screening, it's going to be even harder to get those situations that are more clinically difficult, as mentioned by that question.
Yeah. Another quick question. I think I know how you're going to answer this, but if you have a high copay, let's say you're on Medicare for insulin, what's the best strategy? Get the cost on the insulin or waive the copay?
Okay. Yeah. So this is why I think our connection is breaking. I wish I could say. So we at the Viva Center have taken a very strong position that we are not smart enough to deal with the total price of a University of Michigan hospitalization, a visit to an ambulatory care surgery center, or the price of insulin. We have been very fortunate to get very broad receptivity that patient out-of-pocket costs for things like insulin should be low. I have met with all the constituents, and I was introduced to a Senate briefing as someone who's been willing to get into the middle of the circular firing squad between the people who make the stuff and the people who buy the stuff and the people in the middle, like the PBMs. I really do believe, and have heard from the pharmaceutical manufacturers, if they were able to have their volumes go up appropriately and have barriers reduced to high value care, particularly not just insulin, the really high cost, very exciting drugs that we're using in our specialties, that there would be less pressure for per unit price increases. Now that's all theory, and that's something that we could study, but I've had the attention of not only the Trump administration, but Speaker Pelosi's office on the distinction between out-of-pocket costs and total costs, and real interest on both Republicans and Democrats in the issues of low-value care. And one of the interesting issues that, since it brought up, the U.S. Preventive Services Task Force, in addition to the A's and B's that have to be no cost to patients, they also publish D ratings, which are things that we shouldn't do. And we've been working with Speaker Pelosi's office and the president in following up on a small section of the ACA, Section 4105, that we were involved with, which says Medicare does not have to pay for D-rated services. So I would turn to you, Mr. Chairman, and say, would you have the courage to be the first provider in the country saying, we're no longer going to do screening colonoscopies on people over the age of 85, that we're no longer going to do DEXA scanning on women who do it, we're no longer going to do pay for cervical cancer screening when it's outside the interval. The good news is, before COVID, Secretary Azar's team was looking very carefully at some results that we have on spending on D-rated services. And to the previous question, it's a lot of money that you and I could spend really, really well.
Yeah. I think some of the practice is not to do people over 85 unless you expect them to live 10 or 20 years, but you're absolutely right. I'll give you two more questions. I know we're over time. So one question has to deal with lifestyle diseases, smoking, being sedentary, obesity. These are common diseases, but how should that be handled? These should be the high value care, or is this low value care, or should that be part of healthcare costs?
Yeah, so it's a really good question. I think that this is where you turn to, my division members or even IHBI members. The issue is that we know that, say, for instance, a statin is much more effective in some of those people who have these lifestyle conditions than healthy people who just have a familial mild increase in hyperlipidemia. And if the number needed to treat is lower for people who got there, whether through lifestyle or genetics, than people who didn't, the theory would argue that you make the intervention that's most valuable least expensive. So in the world of colorectal cancer screening, a good example is people with familial polyposis, in my opinion, should be paid to get screened. And 40-year-olds that we showed with Sandeep Fijan and Brahmaji and others that showed that the 40-year-olds who got screened and your institution got paid for no-risk patients after Katie Couric went on TV with her where the colon cancer screening, they should be fined for getting that testing. Now, that's VBID 20.0, which is why I Just Want Colorectal Cancer Now, thanks to Section 2713, is covered at no cost between people age 50 and 75. There are a few people on the outliers, and that's why, most importantly, John, we need clinicians deciding what the guidelines, the payments, and the cost sharing should be, not administrators.
Yeah. Okay, I'll do this the last question because I know we're over. Do you agree that societal expectations for good outcomes and the malpractice environment in the U.S. influence the demand for low-value care?
Yeah. So that's one of these. All your questions are the ones I would have screened out. So the role of litigation. So we've been doing this a very long time, and we've answered these questions for a very long time. The issue of litigation is always used as an excuse for people to do more low-value care. It's interesting, we see in states that have really protective malpractice scenarios compared to states that don't. There's really little difference in physician behavior. I really believe that this is a culture. I really believe that the training that even myself used to be partially responsible for, that we needed to know for the sake of knowing. And, to listen to certain people say, oh, why don't you try it even though if you don't know that works, right? This, because of our fiscal constraints and because we have so many proven high-value technologies, we are going to have to start making tough decisions. Or, as I said in my slides, there's one of three ways. You pay for it in terms of premiums every month, the healthy and the unwell. You kick the can to the unwell, which has gone on in the 20 years I've been doing that, which really upsets me. That's the motivation for our work. Or we have to figure out a way to either lower prices or lower volumes on low-value care. Lowering prices is a pipe dream, right? I can't imagine that you would support that for the service your departments. So that's why I say that's above my pay grade. So luckily for me, and unluckily for some, that there is a boatload of low-value care, which is the focus of our work for the next few years. And because of VBID-X, we have seen really strong responses and encourage by public and private payers to say, if the doctors say we shouldn't be doing these things, we shouldn't pay for them anymore. And our own institution, thanks to Chris Petrelli, we don't have vitamin D testing anymore. We've stomped out vitamin D testing in many national insurance programs. And I should say to you, if there are other questions, because I'm capitated, if I were fee for service, I would charge you by the question. But if you have questions, I'm happy to stay on as long as you want.
All right. Thank you, Mark. I think we're way past time. Thank you for a wonderful discussion of VBID. Thank you for all your work you've done over the last couple of decades in this regard. And hopefully we'll get to that high value care and low deductibles for all of our patients, no matter what their insurance is. Really appreciate it. And thank you for presenting today.
It's my pleasure. I just hope that Marcus Gear and Kevin Platt are the only two folks sleeping right now. Appreciate it, John. Thanks.
All right, thank you. And that will end our grand rounds today. So thank you, everyone, for signing on, and thank you for your questions.